Thank you again to everybody for joining us today, and welcome to the first talk in what we're actually hoping is going to be a three-part series, but is currently slotted for a two-part series around lactation support, and the third part also being a really emphatic focus on breastfeeding equity. And I'll talk a little bit more about that third session we're hoping to plan on August 25th in celebration of Black Breastfeeding Week. It's so wonderful to have you all here tonight or today if you're joining us virtually at some other time. We appreciate you taking the time and space to join Asaiah and I in conversation around lactation. And so first things first, I would like to introduce our wonderful host, Asaiah Harville. Asaiah is an IBCLC, and she's the Birth Equity Coordinator for Cherished Futures for Black Moms and Babies with the Public Health Alliance of Southern California. Prior to joining the Alliance, she worked as a lactation consultant in a hospital providing lactation education and support for families. She has also created and taught prenatal classes on breastfeeding for the community free of charge. She started and facilitated a mommy support group and also helped start the first outpatient lactation clinic in South Los Angeles to address disparities in breastfeeding rates in the area. She's worked as an outpatient lactation consultant in peds at Kaiser at Baldwin Park, and she also has a commitment and passion to support Black families and other historically underrepresented populations as they navigate their journey of parenthood and infant feeding, identifying breastfeeding as one of the solutions to Black maternal and infant health disparities. And so thank you, Asaiah, for taking the time today to share your wealth of expertise and knowledge with us.
Well, thanks for having me. I'm super excited about this. It's crazy how, we talked about this for so long and now it's actually here. So I'm really excited to be here. And I actually have the pleasure of introducing my friend and colleague, Candace Gragnani. Dr. Candace Gragnani is an adjunct assistant professor in the UCLA Department of Medicine and on faculty for the UCLA Preventative Medicine program. She's the director of the UCLA Pathways for Students into Health Professions program for disadvantaged undergraduate students interested in public health and health professional careers, and the co-director of the UCLA Center of Excellence in Maternal and Child Health graduate training program. She additionally serves as the chapter breastfeeding coordinator for AAP California Chapter 2.
Thank you so much for the warm welcome, Asaiah. And apologies, but for the next couple of minutes, we're going to go through some necessary housekeeping items. So if you didn't have a chance to grab your snack, now is also potentially a good time to do that. Asaiah has no financial disclosures to report. I do have a financial disclosure to report. Just of note, I was a researcher on a Pfizer funded study evaluating pediatric COVID-19 household transmission a couple of years ago. This is a financial relationship with an ineligible company per CME regulations, but it has been mitigated by Peerpoint Medical Education and the American Academy of Pediatrics, California, Chapter 2, and is not an issue for today's presentation. So we also wanted to thank all of the individuals and entities who've helped support the planning and the execution of this learning session we're all taking part in. So this educational series is being supported in part by the Black Maternal Health Center of Excellence at the Charles R. Drew University of Medicine and Science with funding from the Conrad N. Hilton Foundation. It is also being supported in part by the Health Resources and Services Administration of the U.S. Department of Health and Human Services as part of a grant award for our UCLA Maternal and Child Health Center of Excellence, totaling annually around $378,000. The contents that we're presenting today are those of us, the authors, presenters, and don't necessarily reflect or represent the official views, nor are they an endorsement of HRSA, HHS, the U.S. government, or any other supporting entity or institution. All content and information we discuss today is meant for informational and educational purposes only. If you are a community member who's happened upon this recording or the information we are providing, it is important to know that no material is intended to be a substitute for professional medical advice, and to please always seek the advice of your qualified healthcare provider with any questions you have regarding a specific medical condition, diagnosis, or treatment. Any ideas, questions, content, or statements made or discussed by us today are our own, and they shouldn't be construed as the official position of or endorsements by our employers or entities that fund projects or research we take part in. And I also just wanted to thank AAP California Chapter 2 and its Executive Director, Tomas Torreses, for their help and their support alongside us in making this session possible. Whew, we're done with that. Sorry, guys. Thanks for joining us on the ride.
All being very, very important parts, so no
Yes.
worries. And so I'm going to jump in here really quick before we review the objectives. And this is something that I do in any large presentation, because I do think it's important that we recognize some of the changes that are happening in society. And so throughout this presentation, I do use the terms mother or mom, women, and breastfeeding as shorthand for all people who get pregnant, give birth, and in terms of infant feeding. However, I also recognize and acknowledge that this is not necessarily how everyone identifies specifically with these terms. And I encourage the use of the terms that your individual patients identify with whenever you're supporting them. And that's something that I have practiced for my entire, the nature of my career and professionally, because it really is important to acknowledge that and to understand that not everybody views themselves in the same way that we might see them externally. So I always like to give that little bit of a disclosure.
So just in terms of orienting ourselves for this session and for the other sessions in our series. So again, this is the first part of a two-part series, hopefully three-part series on lactation, lactation education and support, and lactation equity. And after completion of the entire educational series, our goals are to have you, the learners, and me, myself, also a learner, be able to identify commonly faced problems by breastfeeding mothers, identify common hunger cues in newborns and infants, discuss the safe storage and use of breast milk, create a feeding plan for breastfeeding infants with a variety of common issues, discuss strategies at the outpatient level to enhance ongoing support of lactation for caregivers, and again, bring an equity lens and discuss how culture, systems, and structures impact breastfeeding journeys for mothers from a variety of backgrounds. And just to reemphasize, today we won't get to all of these objectives. Again, this is our goal for the entirety of our series. Hopefully you'll be able to join us for all three of our sessions, but if you're not, please make sure to register for them still, and you can always watch the recordings afterwards and still be able to receive CME, even if you're just able to join and watch the recordings. I also wanted to let you know that Asaiah and I are very open for conversation, and today's session is hopefully going to be filled with dialogue. So please feel free to chime in at any point. If you don't feel comfortable unmuting yourself, you can always type things into the chat box. I will be helping monitor the chat box and draw attention to it if Asaiah is on a roll, teaching us some important things. So we hope you'll join us in conversation today.
For sure. So with all of that said, why don't we get started? So as Candace mentioned, really the goal for today is to provide some baseline knowledge around common lactation concerns, but then also to provide examples of action steps that can be taken to address these various concerns. And again, we're not going to get to all of the objectives in just this first session, but we hope that throughout the series, you're able to develop and improve your knowledge around how to address common lactation concerns and hopefully improve the way you address your practice with your patients. So let's get started. We can't talk about anything related to lactation until we talk about establishing and maintaining milk supply. So rather than go into the whole physiology of how breast milk is made and things like that, let's just talk with what I would like to think is some already baseline knowledge and really an overview of how milk making works. And so whether you work in an outpatient setting or an inpatient setting, it's really important to recognize the mechanism of how breast milk is made, because it really does help to inform and develop the appropriate feeding plans and appropriate guidance for parents based on what's actually happening with them and with their own body. And so in the most simple of terms, the way milk works is on demand and supply. The more we demand the milk from the body, either by a baby directly breastfeeding or the expression of milk via hand expression or a pump, the more frequently that's done, the more we can support the establishment of a full milk supply. But I like to kind of reorient folks to what that means and what a full milk supply means. Milk actually starts being made during pregnancy. So a lot of times you might hear patients say, I don't have any milk, I don't have enough milk. This is especially common both inpatient and outpatient, but we hear it in an inpatient setting a lot. And so we want to remind parents that the milk actually starts being made during pregnancy. It can start as early as 14 weeks gestation. Generally, it happens between 14 and about 20 weeks of pregnancy. And so when we're thinking about establishing a milk supply, it really is speaking to establishing a full milk supply and increasing the volume of milk that we already have when we are gestating. The milk that starts being made during pregnancy is called colostrum. I'm sure you guys are all familiar with that term, but something that I like to emphasize in my presentation is that colostrum is milk. Oftentimes we try to separate those two. It's like, oh, I only have colostrum now, or I only have milk now. And colostrum is milk. And so the more we kind of remind ourselves of that, the more we can remind our patients of that. It's obviously a very highly concentrated and specific to meet the needs of the baby who's really coming into a non-sterile environment after being in a very sterile environment for a very long time. So this colostrum comes in very small amounts. They can be varying colors. They might be clear. They might be gold. They might be white. They might be honey colored. We don't really care about the color. We just know that it's perfect for the needs of this newborn baby. So we always want to encourage our newly delivered moms, especially, that this colostrum is really perfect for what their baby needs based on their tummy size. And we're going to talk about tummy size a little bit later. And so the reason why, when we think about demand and supply, the reason why the frequency of feedings is so important is because after the placenta is delivered, which actually is what triggers lactogenesis 2 or the increase in milk volume, the frequency of feedings or milk expression is what is required to increase that milk volume. So the common term that you hear is, my milk hasn't come in yet. And so again, if we remind ourselves and our patients, your milk already was there, we're just wanting it to increase in volume, we can then think about how to better prepare them and to better support them. Another question that we often get, even before we know about the parent's milk volume, is how can we increase milk supply? What can I buy? What tea can I drink? What food can I drink? Can I eat? What can I buy or purchase in terms of being able to increase milk supply? And so again, we have to go back to understanding that part of the supply increase is by demanding the milk. So if we understand feeding frequency, we can then better educate the parents on if they potentially might need, a supplement or a galactagogue in order to help support increasing their milk volume, or if they don't need it at all. So the minimum requirement in terms of frequency of feedings is 8 feedings every 24 hours. A common way that we kind of in the lactation world will recommend to remember this is 8 or more in 24. So that's every 24 hours. We want this baby to feed at least 8 times. More is always better, just a hint. So if moms are concerned about milk supply, encourage them to feed their baby more, right? Because the more we feed, the more we're stimulating the breast, the more milk we're going to make. One thing that I will note is that the tendency is really to want to divide 8 into 24. So both parents and providers will often say, oh, so every 3 hours, right? So mathematically that's correct, but it may not actually reflect the unique needs of the mother-baby dyad. So some babies will quickly develop a routine and they'll show hunger cues every 3 hours. My first child was lovely. She was like the poster child for this. She was very much on cue on every 3 hours. My second child, not so much, right? And so these situations are very unique, and it shouldn't be a representation of how we approach every mother-baby dyad. But what's more important is really to educate the parents on how to identify hunger cues, which we're going to also discuss in a little bit. And babies are actually really smart. I so appreciate what they can offer to us because they're so smart that they provide all of these cues for us. And even when we miss, they still love us, which is really nice, right? But I will say, as smart as babies are, I have yet to meet a baby who is born knowing how to tell time or knowing how long it's been since their last feeding. So that's why we added this picture of these freaking out clocks, because we often have parents and providers sometimes who freak out about the time. Remember that the baby has no idea how much time they've been at the breast, how long since their last feeding. So again, it's really important to identify those feeding cues and hunger cues. And if we educate parents on identifying those hunger cues, we can eliminate that kind of clock obsession that we have and that parents can have, and really only have to worry about feeding at particular times if the feeding plan necessitates that. So when we're thinking about, establishing supply and maintaining milk supply, there are some subtle differences between inpatient and outpatient guidance on establishing milk supply, but there really is a lot of overlap. So inpatient guidance should always include a review of hunger cues with the family. And I like to say that review shouldn't just be verbal. Ideally, we're giving them some sort of handout, a one-pager. There's tons of resources available for what hunger cues look like. And the reason why that is because moms who just delivered a baby aren't really going to remember most of what you said, let's be honest, right? They just went through a very, a traumatic, for lack of a better term, event, right? Because the birth of a baby, whether it is a positive outcome or not the outcome they expected, it's a traumatic thing for the body physiologically. And so because we're in that sort of mindset, it makes it very difficult to recall and remember, you know, specific things. And so we hear that commonly as mommy brain. Mommy brain's a real thing. I tell moms all the time. It doesn't mean there's something wrong with you. It just really, if you think about it, means that the part of your brain that's devoted to, you know, mathematical equations and planning ahead and all of those things just takes a little nap, while the bonding side of your brain will allow you to bond with this new baby. So again, it's really important that we are providing some sort of handout or something tangible, and also including the family member, friend, partner who is available, because they're going to be more likely to remember and remind the mom after they go home. So when we're thinking about hunger cues, in addition to that explanation of what it looks like, something I like to also remind folks is that while most babies give each and every cue, some may do it more quickly than others. So when we're looking at, okay, your baby will do this and then they'll do this, some babies will go 0 to 100 in about 3 seconds. And so if we miss all of those cues and the baby is now crying, the baby is like, hey, by the way, I showed you all of those things and you weren't paying attention to me, so now I'm upset, right? So educating parents that hunger cues happen before crying, that crying is a late sign of hunger, is a good way to help teach them how to observe their baby, to be really attentive to their baby, and then they can better latch the baby. When a baby is crying, they don't want to latch. You have to calm them first. So that's just another thing that we can help counsel parents on. And so again, if the parents only describe knowing that their baby is hungry when the baby is crying, we do need to pay special attention to how we educate those parents on all of those hunger cues that come before crying. A way that we can assess patients' knowledge on that is just really simply asking the question, how do you know when your baby is hungry or when your baby wants to eat? In addition to that education on the inpatient side, parents really should be prepared and educated for what to expect post-discharge. So that might include a review of feeding frequency, something in the lactation world that we call second night syndrome, which isn't really a syndrome. It's just helping parents understand that while their babies might have done really perfectly inpatient for the first 24 hours, they do sometimes go home and lose their mind and seem to forget what they're doing and how to latch, which then freaks out the mom, because then the mom is like, I don't understand, this baby was so perfect the last night. So we call it second night syndrome. Again, it's not a real thing, but if you prepare a parent to say, hey, this might happen when you go home, they better are able to manage that when that comes up. And then outpatient guidance should really include the review of the feeding frequency, feeding assessments whenever possible, and feeding plans that will help the parents meet their individual feeding goals. So something that's also really important is that while we bring knowledge and sometimes education to this feeding assessment or to this dyad, it's really up to the parents what their feeding goals are. So oftentimes, we have a particular goal in mind that we want for all families, right? I want all families to be able to breastfeed. I think that that's amazing. I think there's benefits, et cetera, et cetera. But I don't go home with these families. I'm not taking care of these babies. And so it's not about what I'm wanting them to do. It's really about supporting what their particular goals are. And then something else that's really important for both inpatient and outpatient clinicians is that we often will really hear that the family members, the support person, the partner is really concerned about milk supply. Maybe they were not breastfed. Maybe they've never seen someone who was able to successfully breastfeed. And this can be true whether it's the first baby or the third baby. This might even be true for the mom, right? She might have concerns about her milk supply. And so what's really important is how we educate and support the family. Just because mom struggled with breastfeeding for the first baby doesn't mean that will happen with this new baby. Just because the first or second baby had latching issues doesn't mean that that will happen with this baby. And I think it's really important to remind parents, again, this could be their fourth or their sixth, that every baby is really different. And even a mom with experience has actually never breastfed this particular individual baby. So it's going to be really a learning experience for both mom and baby. So we want to provide reassurance, we want to provide encouragement and support. And if you don't know the answer, I would always offer that you should find a lactation consultant who does, right? Because we're not in this alone. We're not meant to know all of the answers. I don't know all the answers. I just know based on my experience. So that's going to be really important. So the next thing that I hope to do, and we're going to do this throughout today's presentation, is to actually have some dialogue about some sample cases, because I want to hear from you all what you would recommend or what feeding plan you would develop for these particular cases. So let's go to case number 1. And again, feel free to unmute yourself. I don't know if everybody has the raise hand function, but if you want to use that, feel free to put in the chat if you would like. So let's take a look at this first case and see how we can apply some of that information. So baby A is inpatient and is 18 hours old, was a vaginal delivery at 39 weeks and 5 days to a first-time mom who desires to exclusively breastfeed. Mom is concerned that she will not make enough milk because of what family members have told her about their breastfeeding experiences. Baby's birth weight is 4,100 grams, and baby has had 2 urine and 2 stools at 18 hours. Mom and baby will be discharged at 24 hours. So let's talk about it. How would we counsel this mom? What should be her discharge feeding plan or feeding instructions? And what guidance would we give this mom to go home with? The goal of this part, again, feel free to answer. There's no such thing as a wrong answer. Well, there's such thing as a wrong answer, but what we want to really encourage is this dialogue, right? Because again, this might be, oh, that's super easy. I can handle that. But based on the information given, oftentimes we don't always feel comfortable providing particular guidance or instructions. So would love to hear from the folks participating what your discharge feeding plan might look like, what guidance you might give this mama to go home, and how you might counsel her. And maybe Candace, you can help, because I can't see folks, so maybe you can help me.
Yeah,
okay, perfect.
Jocelyn, you have your hand raised, so I'll go ahead and unmute you if you wanna chime in. Thanks for offering some thoughts.
For offering myself as tribute, is that what you were gonna say?
Yes.
May the odds be ever in your favor.
So I think what strikes me about this is not just that this is like such a classic source of anxiety for so many first-time parents. So I think I would educate on everything that you've already presented, Asaiah, as far as milk production, synthesis, and increasing the volume with supply and demand. But I think that what this kind of the first focus would be alleviating her concerns and also giving her a sense of, or helping her see that sense of empowerment. Like, she did something extraordinary in carrying a pregnancy to term and growing a healthy, beautiful baby that is already such an overachiever with 2 voids and stools. Like, that's amazing. Great size kid. How spectacular is her body? And then kind of going into all of that education in addition to all of that. Like, because I think that people come in with so much of that anxiety, and when it's exacerbated by the support system, it can be a little difficult. So I think that my approach would be like empowerment followed by the science and the evidence, and then also making sure that she has lactation follow-up for outpatient, so that she has that support outside of her family as well.
Awesome.
Thanks so much, Jocelyn. That's awesome.
Hope, do you want to chime in with some of your thoughts as well?
Oh, she's still on mute, Candace.
There we go.
There
Sorry,
we go.
I just unmuted you.
Okay, so everything that the last person just said, and if the family has told them about all of their breastfeeding experiences, then she's heard the horror stories, especially about pain. And so I think if there was one thing I would focus on is reinforcing that it's not supposed to hurt, and that if she's in pain or discomfort, she needs to ask for assistance rather than try to tough it out. That's where I see big challenges, because by the time they get back to you, their nipples look like hamburger.
Nobody wants that. That is
No.
never fun. And just to point out in the chat too, Asaiah, Lilia also mentioned, echoing some of what Hope and Jocelyn have said too, in terms of reassurance regarding breastfeeding, giving expectations in terms of adequacy of milk supply, and kind of preemptively providing some solutions for sore nipples as well. And Amanda, I'll go ahead and unmute you as well.
I would also be asking who is an ally in the house. If you identify an ally in the house, and if they happen to be there with you, giving that information to them so they can be that support system. And sorry, my dog. Also, too, when we give the education, I would encourage more emotionally driven messages to the parent, because sometimes when we do so scientific and clinical, this is how many poop, how many diapers, it tends to go over their head, because I get to see them in the children's hospital and sometimes they're not remembering anything, but they do remember the more emotionally delivered education on those points.
Thank you so much, Amanda. And then the last comment was from Carolyn, and she talks about assessing mom's ability to evaluate the feeding, particularly because it's a 24-hour discharge, highlighting the importance of the anticipatory guidance, and giving her some signs about, I think this gets to Hope's comment too, right? Like if it's going well, it shouldn't hurt. So what are some other signs that things are going well? And I see Annika, I hope I am pronouncing your name right. Please correct me if I'm wrong. I'll go ahead and unmute you as well.
You're getting my name right. So what I see in many of my new moms is that, especially if they have been told horror stories by their family members, is that they want to prove them wrong. So they want to be overachievers, right? So they have to show that everything's going perfect. And right from day one, they're making all their milk supply. And if they have pain or discomfort, they do not want to complain about that or talk about it, because that means they are validating what their family members said. And now they want to prove that they can do it. They can exclusively breastfeed without complaining. So what I talk to them about is that, you're not going to see 2 ounces every 2 hours right away. It's going to build up, and pain is normal. Sometimes we have to address that. Many mothers can go through that, but you need to speak up if that happens and if it's persistent. And anytime you feel vulnerable, talk about it, right? You are a superhero because you went through all this, but you are still a human being. You're going to have some problems, some things to deal with, and you need help when you need to ask when you need help. So you don't have to prove anything to anybody. It's your journey. It's your process with your little child. So just allowing them to say that it's okay to be vulnerable, it's okay not to be perfect, is like a lot of burden out of their system. So that would also help to kind of, talk to them about realistic goals.
Love it. I'm loving all of these responses. You guys are obviously brilliant. You should all become IBCLCs if you're not, because we need more people like you all, right? Like, you nailed it. I think something that is so often like forgotten about, as someone mentioned, is we kind of give folks measurable things that are clinical in nature, and we don't really speak to that emotional side. We don't really speak to the side that's more counseling, right? And so I think that that's something that we always want to consider, even in complex cases, right? Even when we're thinking about the cases that are not as straightforward as this particular one, is how do we connect with our patients on an emotional level? Because if we think about it, that's actually probably the part of the brain that's most in tune with what's happening. So as someone also mentioned, moms are not going to remember a lot of things, if a lot has happened with this particular baby, or even if everything is fine. It's this idea that we want to engage folks from where they're at. We want to involve partners whenever possible, and we want to give guidance that's appropriate for that particular situation. So while a feeding plan might be really specific to a baby, oftentimes guidance can also be very specific. So it doesn't have to be, well, we tell all moms A, B, C, and D. It's really listening to what they're saying, listening to if there are any potential barriers, which we're going to talk about later and throughout the series, and addressing those things as needed. So because we already kind of talked about guidance for going home and how we would counsel this mom, let's just really look at what a feeding plan might look like, right? All of the boring stuff, because you guys got all of the stuff that's really important and how to engage. But we also have to think about what this feeding plan might be for discharge instructions. So feeding plan for baby A, continue breastfeeding on cue and on demand, because we're reminding mom that It works on demand and supply. That's going to address some of her concerns about milk supply. I also, because this baby is inpatient, I always encourage all moms, but especially inpatient, to learn how to hand express. Sometimes it's amazing when you see a mom who sees her own milk and sees her body doing exactly what she wants it to do, but maybe she's not as confident to do. So if at all possible, we want to refer to lactation and or a nurse that's really strong in lactation support, or if you're a physician and you feel comfortable, feel free. But teaching hand expression is a wonderful way of building mom's confidence and building the family member's confidence. And as someone mentioned, giving that praise when you see it, right? Oh my goodness, look at how much milk you have. You are a rock star. This is why your baby is already so smart. Look at all of the things that your body has just done in the last 18 hours, right? And then we're continuing to educate. We're educating on feeding cues. We're encouraging skin-to-skin contact, because that's, again, going to speak to more of that emotional thing where mom will be able to recognize baby's hunger cues. Baby will likely get fed more frequently. So we're going to, again, talk about the 8 or more feedings, but if we're doing lots of skin-to-skin, that baby is going to tell mom when he or she is hungry, right? Allowing baby to be at breast for as long as baby's actively sucking with pauses for swallows. That's another thing inpatient that often gets perhaps misunderstood, is this idea that, well, he's taking too long. Well, how long is too long, right? And so again, thinking back to that clock, the baby doesn't know how long is too long. They just know that I like it here. It smells like mom. It smells like amniotic fluid. This place is safe. I'm going to stay here for as long as I can. So encouraging them that that's okay. Educating on diaper counts for the first 7 days. This is a wonderful job for the partner, let me tell you, because mom, again, has a lot going through her mind, going through her body. And so whoever her support person is, we're giving them jobs. And I like to give dad or partner the job of diaper counts. Let's count it for the first 7 days. Let's see what that looks like. Let's also think about how that means if something's coming out, something's going in. So that then speaks to that concern about milk supply. Again, providing reassurance and praising mom for efforts and requesting lactation whenever possible. So that is a great plan for this baby. And you guys already knew all of the counseling stuff. And I'll tell you, lactation is like 20% clinical and about 80% of the counseling piece. And you guys are already well on your way. So I'm really excited to see how you come up with feeding plans for the next few babies that we have on this presentation. So we are going to move right along. So past establishing, maintaining milk supply, we want to talk a little bit about the outpatient side. So thinking about feeding assessments at the newborn exams. And so obviously weight loss is a major topic of concern for both parents and providers. And it's really important to manage expectations of parents for what to expect at the newborn exam in terms of weight. For my inpatient providers that are on the call today, I encourage having that dialogue when possible. Things like, what your baby weighs in the hospital will likely be more than the weight you see at the first newborn exam in your outpatient newborn visit. This is pretty common, and your outpatient provider can guide you through what that looks like and how to address it. And when patients used to come to my outpatient clinic, it was too often that they were surprised that the baby weighed less than the birth weight. And that's really unfortunate, because I think that had they been given just that little bit of information, they wouldn't have felt this increased sense of mom guilt, which, mom guilt starts during pregnancy really, but it continues throughout the feedings. And so if no one educated them on this being common, they then feel like they've been doing something wrong in terms of feeding. They have, somehow let their baby down, let their family down. And we don't want them to come in with those feelings, because society is already going to pressure them enough that they're not doing anything right in terms of parenting. So part of anticipatory guidance for weight loss will include those pieces of information that are important to the parents. We don't need to give specific numbers. We don't need to give percentages. We don't need to be super clinical, just really tempering and setting realistic expectations so that they are not surprised if they hear some of those things in their outpatient visit. And so when we're thinking about outpatient, ideally babies are seen between day of life 2 and day of life 5 for their first visit. My personal preference is if I'm seeing them would be for lactation on day 3. And that's really because it's hard to measure a transfer of milk because the baby's tummy is so small on day 2. It doesn't mean we can't do it, doesn't mean we shouldn't do it. And there are, of course, other needs that need to be assessed. So if a baby is scheduled on day 2, that's also totally fine. Often, though, I've found that parents have expressed frustration and even sometimes anger with being discharged the day before and then required to come back the next day for an appointment after they've just birthed a whole human, right? They didn't get sleep in the hospital. They didn't get any of the rest that they thought that they were going to get. And now they're having to come back for a newborn exam. So, you know, if all things look normal with baby, I would encourage folks to try that day 3, if at all possible, just to give a little bit of a break to the families. And so again, on day 2, it is a little bit challenging to do a feeding assessment from lactation, but it's definitely possible. If you're an outpatient provider and you see a baby in your clinic that does not include lactation or a feeding assessment, it's still actually important to assess how feedings are going. And so the way that we can assess how the feedings are going is by asking mom and family questions about feeding frequency. So we're remembering that 8 or more feedings every 24 hours. If mom is describing any pain or difficulty with latch, this might also actually signal that baby's not getting as much milk as possible, because a poor or improper latch often actually coincides with baby not effectively stimulating the breast and therefore not transferring as much milk. So if you're hearing that, you want to know your lactation resources and refer ASAP for a full feeding consult. And the number one reason why moms stop breastfeeding is due to nipple pain. So if we can alleviate that from the beginning and get them support and full assessments with a plan with a lactation consultant, we hopefully will alleviate the number one reason why moms will stop breastfeeding. And so if we can assess and correct that source of pain, mom will be more likely to continue and sustain her breastfeeding relationship. Something else that's important is that a common weight loss trigger in the outpatient setting is the number 10, so 10% of birth weight being lost. It's usually when providers see that 10% that they want to start supplementing. But unfortunately, without a full feeding assessment and assessment of milk transfer, we don't actually know if supplementation is necessary, nor in what amount supplementation is necessary, if in fact it is. And so in lactation, we can actually assess a feeding to see how much baby is drinking. Obviously, we can do a latch assessment, positioning, et cetera. And then we can apply that information to the rest of this dyad's experience. So a mom with a long labor, for example, and has received, extended time receiving an IV fluid or epidural may actually have a baby who shows a higher weight loss simply because they received that extra fluid too, and then lost it in the first couple of days. So we would want to know what the birth, what happened at the birth, what were some of those contributing factors to really be able to paint a full picture about what's going on with this dyad. And then feeding plans for weight loss really should be driven by that full feeding assessment, knowing all of that background knowledge. So it's not simply the number 10 weight loss percentage that we're looking at in terms of whether we decide to supplement or not. Really, recommendations about feeding plans should be developed based on all of the information we have access to, asking mom those questions, and it definitely needs to focus on including and elevating mom's individual feeding goals, her access to support, and her ability to follow through with whatever recommendations. So again, I might have a very detailed plan for a family based on the weight loss percentage, based on what the feeding assessment says. But if this mom is more concerned with, her other children that she has to take care of, or if she's a single mom and she really does not have capacity to do additional feedings or supplementation, that might actually hinder her desire or her ability to want to continue with breastfeeding. So it's really important to also assess some of those social determinants to really help us figure out what makes the most sense for this mom. And then again, in terms of recommendations based on feeding, the amount of any supplementation is really dependent on how much the baby drinks at breast. And we can think about supplementation in a couple of ways, but it should always start with mom's own expressed milk before anything else, then human donor milk as the second option, and formula as the third option. However, I will say there's a caveat, because a baby at 2 days is a little bit different than babies that are seen at day 3 or beyond. So a 2-day-old at 8% weight loss might require the same feeding plan as a baby that's 3 days old or later with more than 10% weight loss. So again, that's something to remember, to keep in your own mind, to be able to develop those feeding plans. And in lactation, for this baby that might need to be supplemented, we would refer to it as a triple feeding plan, meaning that mom is going to be doing a combination of direct breastfeeding, expressing or pumping her own milk, and also giving baby that expressed breast milk. So with that given information, let's move on to case number 2. So I'll read it out here really quickly. This is another case but a little bit of a different situation. So this is baby outpatient, baby B, presenting for newborn exam on day of life 3. It's a vaginal delivery after a long labor with an epidural. Baby delivered at 40 weeks. Baby is exclusively breastfeeding. Mom's 3rd child. She breastfed the first 2 children exclusively for over 1 year. Baby's weight loss is 10% of birth weight. Mom states breastfeeding is going well, no pain or difficulty with latching. What are the feeding plan recommendations for this mama, and what does follow-up look like for this dyad? So again, same deal. Feel free to raise your hand. Candace will unmute you and let me know what you think. How would we counsel this family?
Hi, everyone. I'm Rosemary Bird. I'm one of the Preventative Medicine Fellows. Thanks for having this lecture. And I would start off on really 3. She's doing very well. It's her 3rd baby. So it sounds like she knows kind of what to expect. The other children were also breastfed, so that is reassuring. So I would then go ahead and just continue counseling her on proper feeding every 1 to 2 hours, not going longer than 3 hours. And just, it takes time. By that 2nd week mark, we want to gain back that 10% of birth weight. But as you stated today, they may lose more weight now because she had the epidural as well. So I would go ahead and explain that to her as well. And continue, congratulating her and stating, making sure she wakes her child up and doesn't feed more than every 3 hours. And I'd probably, since it is at 10% of the birth weight, I'd probably have the baby come back in a few days just to be cautious and recheck the birth weight. I probably wouldn't wait until that 2-week mark. So maybe in day like 5 or 6 to come back for a weight check.
And Asaiah, I think Lilia has a question that maybe some other people are also wondering about, or a comment. She was talking about whether or not the baby was jaundiced might kind of dictate what her plan and recommendations would be. And then Amanda also has a comment. So I'm not sure which order you want to do that in.
I guess let's address the jaundice piece first. So it's a great thought. And I will say that for this particular baby, we're only going to go with what's on the screen, because we will address jaundice as part of this series, but that will be more in part 2, where it's going to be the clinical and more complex situations around lactation, how to support what that looks like. And hyperbilly is definitely one of those. So for this particular baby, we're going to assume that this baby does not look jaundiced, does not have jaundice. All of those things have been assessed and is not a factor in this particular baby's case. And then what was the second question, Candace?
Amanda just had her hand raised, so I was going to go ahead and unmute her so she could
comment. Oh,
comment.
okay, sure.
So seeing this as a mom with a rich breastfeeding experience, I think we also, before we jump into education, let's ask her if, other than it going well and no pain, if she notices a difference between her children. And when you walk through her, like, compared to your other kids, do you notice this? She may pick up on tiny, subtle, nonverbal behaviors that when you have the understanding of the dyad, you can maybe pick up something too slightly. But honoring her experience before I educate her to see what she's seeing, what she's noticing, and if she notices a difference between her kids in terms of this breastfeeding relationship.
Great consideration. I love that. And again, it points back to this idea that we want to listen to what the mom is telling us is happening versus we do want to bring our clinical knowledge and our education and our background. However, this is the first time, because this is newborn exam presentation, right? So this is the first time as an outpatient provider, we're seeing this mom and this baby and the dyad together. So it's really important to take that feedback from the mom so that we can better understand what they're experiencing, because it's not something that, in an outpatient exam, it's usually about 15 minutes for a newborn, right? That's how much they're scheduled for. That is far and away not long enough to do a full feeding assessment. So you really do have to rely on the feedback from the mom, the commentary, her experiences, in order to make what's likely a very quick recommendation in terms of feeding plans. Other thoughts, comments, questions?
Nothing in the chat. Oh, did someone else raise their hand? Oh, Hope has another comment. And Hope had a question about crying, the benefits of crying and mythology around that. Sorry about that, Hope. I forgot to bring that up. So maybe we can tie that into this
question. I love it.
Too. Go ahead, Hope, you're unmuted.
Yeah. So what I run into many times is, yes, the baby has gone back to their provider for a weight check. They're down 5%, they're down 7%, it's day of life 3. And the medical provider will tell the parents, you have to start supplementing right now. You have to. Your baby is dehydrated. And there can be differences in how we see dehydration. I didn't see it, but the provider has told the parents this. And so I know that the AAP, based on some of the comments there's no strict commentary on what constitutes a level or a time for intervention. But as an IBCLC, that's something that I come up against quite often. And I do not have the authority to countermand a doctor's order. And yet I want to support the parent, especially a parent like this, who has some experiences, as Amanda mentioned. And maybe that experience is going to tell me, okay, let me give her another couple days, see how things are going, or she's noticing, the baby is a little sleepier, so we're going to wake them up more often. But what's the guidance there? How do we, as people who are not physicians, work with physicians to support moms who are breastfeeding?
I love this question because I've had this same question myself as an IBCLC. So shout out to the IBCLCs in the room, because the things we hear and the things we experience from our patients, I think, are part of the reason why this series actually even came to be, because there's such a sometimes lack of understanding around lactation, around how it works, around supplementation, et cetera. And we often have our hands tied as lactation consultants. And so what I would offer to that is, you can counsel the parents, because I've had the same situation happen. You can educate the parents, provide research and evidence-based things. And as far as the provider, you can offer to educate them, but oftentimes providers are not receptive to that. And so there is also the option to change providers. If the family does not feel like their concerns are being heard, they are receiving the best care that they could possibly be, especially for this new baby, that's always an option, right? And it's not about, well, you have to stay with this person because you just feel like you have to. And I would just throw it back to the providers in the room, the pediatricians who are seeing these babies in outpatient. Maybe Candace wants to take a crack at this question. How would you, if you're me, your Hope, how do we talk to providers when they're providing potentially harmful information, if we're thinking about it, right? Like to tell a mom that she has to supplement because the baby's at 5% weight loss when she's exclusively breastfeeding is harm. And so how do we mitigate that on the lactation side when we do not have the same authority as a physician?
Well, that is a super loaded question. And I'm really glad that we're bringing it up in this space. And I think Grace brings up like this really huge and important point in terms of being able to bridge relationships and communication between lactation experts and consultants and physicians. And just anecdotally, right? And I think there's a lot of research to show this too. There's such variability and unreliability in terms of the amount of lactation training that pediatricians get, right? In terms of formal requirements, whether that be in medical education, where there's not necessarily a formal requirement, whether that's in your pediatrics training, it's not formally required that you do a full-on lactation rotation, right? And so to some degree, it depends on where you trained and then whatever kind of personal experiences you've had, if you've breastfed or you've supported someone who's breastfed, and what you've taken on yourself to learn, right? But there is such limitations. And I feel like in terms of, if I'm really going to go like pie in the sky, right? I think as physicians, a lot of us feel very uncomfortable with not having the answers or with dealing with uncertainty. And for these kind of more nuanced conversations around lactation support, I think some of us, and I'm guilty of this too, I have been previously, right? We feel like on the side of caution, and that we tend to kind of hyper focus on what will happen if this baby doesn't get enough to drink, right? And so the one thing I feel like I can be certain of, if I tell the mom, okay, well, supplement with formula, this is by no means an excuse, right? I'm just trying to like walk through maybe particularly my early days during training, what sense of comfort I feel like people tend to draw from formula, and it's a crutch, right? It is, maybe I don't feel comfortable giving mom the anticipatory guidance of how she'll know that the baby is getting enough milk, or how she'll know that the supply is good right now, or right. But formula is like a sure thing in that you can measure the formula and you watch the baby drink the formula, and then I feel better because you know how much, right? And I think we too heavily rely on that. And I think I'm rambling at this point, so I apologize. But I feel like those are.
No, I think it's great. I think it's great. And to your point, and I see Lilia has her hand up, so I want to get to her, but to your point about being able to see it, lactation consultants can also measure how much milk baby is drinking. So if you are not comfortable because you can't see it, you should be referring to lactation so that they can actually give you that number. Because again, that number is, for some folks, that's the only thing that will provide reassurance. So if I know that this particular baby in this case is transferring 1.5 ounces every feeding, I have no longer concern about the 10% weight loss. I might simply, and we can actually move, I want to go to the feeding plan and to Lilia, but I don't have a concern because I actually can measure how much the baby's drinking on day 3. And because this mom has experience, because we've assessed her, assessment of what's happening in the experience with this new baby, we can really actually build our confidence level when we do partner with lactation. So it's not this idea that the physician has to know all the things. It's really about how do we collaborate? How do we better partner? How do we utilize the resources of lactation support for our patients to better provide support for our patients, right? Because as Candace mentioned, most physicians don't actually have, the amount of lactation specific training that is required to become an international board certified lactation consultant. You have to do a minimum of 90 hours lactation specific education, in addition to between 300 and 1,000 clinical hours before we're even allowed to sit for the exam. So just something to think about. And Lilia, I see your hand up, so maybe Candace can unmute you.
Hi, everybody.
Lilia.
Yeah, so I guess I feel like I want to speak for the pediatricians a little bit, because I do see a little bit of a barrier between sometimes the recommendations from the pediatrician and the lactation consultants. And I would hate to see that, that animosity and having the patient caught in the middle and feel like the pediatrician is not recommending, is making the wrong recommendation regarding the feeding. I have to say I'm the chair of pediatrics at the local hospital. And before, when I first started being chair, I've been there for like 2 years, and I've been chair before, but we had consistently about 6 to 7 babies that came back to the emergency room with starvation jaundice, with exclusive breastfeeding, that had to be readmitted to the hospital. So from the pediatrician standpoint, we definitely want to prevent having to readmit the baby to the hospital, because all that we do when we readmit them is basically feed them, and then they can go home after they rehydrated. So it's an assessment that the doctors make to try to make sure that the baby doesn't get to that point. In this case, I think it's kind of a hard case because the case you're presenting really sounds like that mom is doing fine, and that the baby, with good follow-up with lactation or the pediatrician weighing them the next day to make sure that they're doing okay and that the milk is coming in, that's not going to be an issue. But the one of the things as a pediatrician, and I'm going to just mention this because this I think is the biggest stumble block between pediatricians and lactation consultants, is the fact that we demonize formula so much that the parents feel like really the breastfeeding is the only thing they can offer, and sometimes to the point where even if formula is needed, they feel like they can't use it because it's bad for the baby. And the last thing I'm going to mention is that for all the baby-friendly denomination hospitals, there is a training that's required for all the pediatricians and all the nurses with proper lactation training. So we do have that benefit of having that training in the hospitals that are baby-friendly. I don't know if all the hospitals are, but that's something that provides extra training, and any pediatrician can take advantage of that. I think is free.
Awesome. I just want to acknowledge the honesty in your response, Lilia, because I think that that's something that is part of the challenge. And really, again, one of the reasons why we wanted to develop this series is because there does need to be increased dialogue between pediatric providers and lactation, because there are so many messages that are mixed and or different from provider to provider, from lactation consultant to lactation consultant. And so that's why this dialogue is so important. And really, the goal is not about, and we're going to talk a little bit about supplementation and what that looks like. But in lactation, a good lactation consultant is not against formula. A good lactation consultant does a full assessment and bases whatever feeding plan based on what's actually happening for this particular dyad. So I know for me personally, that does not ever discount or do a disservice to what formula is. Formula is a medication, and I'm so glad we have formula because there are babies that need it, right? Without it, they would be in really bad shape. And so we're going to talk a little bit about that. And I think there are ways that we can start to better communicate those things to our patients. But I think the problem is that the default for providers is so often formula that they don't protect mom's milk supply. And then mom does have this it's kind of like this, it's a slippery slope, right? It's like mom wants to exclusively breastfeed, provider is telling her this, lactation is telling her this, and we either stress her out so much she wants to do none of her plan, or she just doesn't continue to go to follow up. So I think it's really important that we start having these dialogues, we start assessing, our knowledge internally, but then also using the resources that are currently available. We're going to talk a little bit about them later, but I did put one in the chat around the Academy of Breastfeeding Medicine's clinical protocol for supplemental feeding. And it's not ever going to be either directly breastfeed or formula. There are steps in between. And so we have to make sure that we're following those steps, because then we can better, educate and support this mom and really feel better about what we're doing in terms of feeding. So I'm going to go really quick to just this particular case's feeding plan, and it's pretty simple. This is what I would do for this mom if I did not know how much the baby is drinking. So as someone mentioned, doing a quick follow-up. If I don't know how much baby is taking and I only have 15 minutes and mom is expressing that everything is going fine, there's no differences, the baby is actively feeding, etc., I'm going to encourage her to breastfeed on both breasts every 2 hours. Encouraging both breasts will help to make sure that that baby gets enough milk, because baby may start off on one side, get a little sleepy. We want to wake that baby up to do both sides for every feeding starting on day 3. The second piece that's really important is following up in clinic sooner rather than later. So especially if we do not have lactation support available and we do not do a full feeding assessment where we can measure how much baby is drinking, my recommendation would be to follow up next day or in 2 days for this particular mom. And so that's how I would approach it. And again, I would always reference that if you have access to lactation, utilize them, because they're going to give you more information to help you and the family make an informed decision. And if you feel comfortable, if this baby is drinking 1.5 ounces every 2 hours, there is really no need for this baby to be supplemented. And we'll talk about what supplementation looks like after. All right, so we have a second case that we're going to just go through really quickly. I'm so appreciative of this dialogue. Let me tell y'all, this is great. And I love the fact that we're starting to build some of these bridges that maybe didn't exist before, and hopefully we'll be able to continue it. So case number 2 is a baby who presents for newborn exam on day of life 2, vaginal delivery at 37 weeks to a first-time mom, discharged at 24 hours. Mom is currently exclusively breastfeeding, but having difficulty with proper latch and has nipple pain and scabbing. Weight loss percentage is 8% from birth. How are we going to provide, or what feeding instructions are we going to provide for this mom? Feel free to, again, put it in the chat or raise your hand.
Hope, let me unmute you.
So at this point, I don't think I've got a plan, because there's still so much that you need to assess. If you know she doesn't have proper latch, if you know she's got pain and scabbing, if mom is in pain, milk's not flowing. It's just not possible. And the tension, and she's not going to let the baby nurse long enough. So at this point, I have no plan, because I need to see how mom is feeding this baby and what it looks like at the breast. Because if she's not comfortable, it's not going to happen.
Great thoughts. Love that. That's how I know you're in lactation.
Yeah, Priyanka was expressing dismay that the first time mom is getting discharged at 24 hours. But to Asaiah's point, it happens, and not infrequently.
It happens, and let's think about with COVID, right? Everybody trying to get everybody out as quickly as possible. This is a result, and this is what happens. First-time moms are getting discharged at 24 hours.
I just wanted to also mention Carolyn's point. This is a little bit linked back to our last conversation, but might come into this one down the road a little bit as well. But Carolyn is also highlighting the importance, which I think sometimes we forget, is to come up with a titration off formula supplementation plan. If that is something that the baby needs, it's just as important as discussing the necessity of it in that moment. So having close follow-up with lactation for that as well is also vital. And I wanted to allow, I'm going to unmute Lilia too, and then we can bring up some more comments in the chat box. Let's go ahead, Lilia.
Hi, everybody. I don't want to take over the show here, but with this one, I would be concerned that the baby is a late preterm baby, which tend to have more difficulties with latch and with feeding, with coordination of sucking. And so that's might be the reason why mom is having so much trouble. But when the moms have nipple pain and scabbing, I have seen moms just break into tears when they come to my office because they're in so much pain. They can't stand it anymore, and they just give up breastfeeding because they think it's so painful. And I have to constantly reassure them, look, when the breastfeeding works well, it is painless. And you have to trust me on this. You have a period of time when you have to establish the breastfeeding. And once you establish it, it's going to be painless. But that reassurance to the mom, and also just support so that her nipples heal. These nipples need a break. And so if you either the nipple shield to give them the break, or you use a supplementation with either pump breast milk, because the pump tends to be less hurtful than the baby sometimes. If she has some milk in there, if there's no milk in there, then formula would be a good way to give the nipples a break. And also reassure mom, just because you introduce formula doesn't mean you have to stop breastfeeding. And that will not jeopardize your ability to breastfeed later. It's just temporizing measure. So that's what I would say as far as my plan.
That's great. I love that. I see Amanda's hand, and while Amanda chats, I'm going to go ahead and just go to the feeding plan, and we can discuss after.
All right, Amanda, you are unmuted.
I just have, this is more of a putting it out there for opinion. Usually when I'm dealing with infants who are near or late term infants, I would incorporate some level of pumping, and to give it a finite plan because the mom may discharge and I never see her again after they come in. I usually put it to, advice to follow up in the community with an IBCLC, but continuation of pumping until their estimated due date to their corrected age, just to ensure to protect that supply that we establish a full milk supply, because they may not be efficient at transferring if we determine that the latch is not optimal. What are your thoughts on putting like that kind of to corrected age, or do you think we should wait till they demonstrate they're effectively latching and we just say, okay, we don't need to do the pumping?
It's a great question. So I think that it would be very much individual based on what I'm observing with this particular dyad, right? So some 37-weekers, as Hope put in the chat, they're great pretenders. So oftentimes they look really good. That's why they get discharged at 24 hours. Then mom is reporting that baby is super sleepy or not, ineffectively sucking. And obviously we can see with this one, this mom has nipple pain and scabbing, which tells me that baby is not latching correctly. So for as a general rule, I don't tend to make like generalizations unless, there is no access to lactation support for this mom. So if I know there's nobody in the community, she doesn't have access, she can't, either go to WIC or see somebody as an outpatient lactation consultant, I am going to make certain recommendations for her. It's probably not going to be pumping. The reason why, or pumping until the full term. The reason why is because sometimes it just takes babies a couple of days. And so pumping is a lot of work for moms. And so if we can alleviate the stress of doing a lot of work in addition to trying to breastfeed, my recommendation would be to fix the latch. Because if we fix the latch, you can actually continue to breastfeed without nipple pain, even if there is some scabbing there. If the latch is fixed, you can nurse directly, and we may or may not have to do supplementation. The concerning part for me is that this baby is 37 weeks, and the weight loss percentage is 8% on day of life 2. So for this particular mom, this is the feeding plan that I would develop, again, based on the fact that I don't know that she's going to be able to see someone in lactation. Maybe the outpatient clinic doesn't have lactation except every other Friday, and this is Wednesday, right? So educating and demonstrating proper latch to reduce and hopefully eliminate nipple pain. The nice thing about scabbing nipples or painful nipples is that a little bit of expressed breast milk goes a long way for healing and for pain alleviation. So again, hand expression is really important for this particular mom as well. Breastfeeding every 2 hours if mom can tolerate on both breasts. So if we've been able to fix this latch and mom feels comfortable, I want her to breastfeed every 2 hours, both breasts for every feeding, using that proper latch. Another option could actually be that mom decides she wants to take 24 hours off of breastfeeding. I've also had that happen. That's just based on what the mom tells me she wants to do. The pain is too excruciating, as someone mentioned. We want to give the nipples a break. That's okay. The important thing here is to protect mom's milk supply as we are trying to establish it. So hand expression for a 2-day-old baby is the preferred method. The reason why is that oftentimes, because baby's tummy size is still pretty small on day 2, if we pump, we're probably not going to get a whole lot that we can visualize in terms of colostrum and as that milk is transitioning. So I don't want mom to feel discouraged of the fact that there's not a whole lot of milk coming out. That must mean I don't have any milk. I'm going to just give up altogether and do formula. Hand expression is a great way to teach mom about her body, to express that milk, to give the extra colostrum to baby instead of it getting stuck in the pump part. And we also don't know that this mom has access to a pump, right? So it's an access issue. We don't know if she can afford a pump, if she has one at home. Even if she didn't have one, if she could order one, can we get it to her in the next 2 hours? Things like that. So if an outpatient provider is able and we can do a DME delivery, which is what we did at Kaiser, for this mom, I would have done a DME delivery. They deliver it within 4 hours. And in the meantime, I'm going to teach her how to hand express. If mom is unable to hand express or pump, I do want to offer supplementation of about a ½ ounce, because that's going to be about what baby can take. And we're always going to start supplementation, if it's not mom's own milk, with human donor milk. So if no human donor milk is available, then formula is after every breastfeed. So I think that's where, when we're thinking about, it's not directly breastfeed or formula. There are steps in between. So it's really important that we think about using mom's own express breast milk as supplementation option number 1, using donor milk as supplementation option number 2, and then formula if those things are not accessible or available. This baby should also get a follow-up in clinic for a weight check the next day. We treat this baby that's 2 days old, a 37-weeker at 8%, the same way that we would treat a full-term baby that's at 12% on day of life 4, okay? So these are just some of the things that, and why it's again important that we can do feeding assessments and we can check in all of those things in lactation, and why it's important to collaborate and to partner with whoever's in the community in terms of lactation. So we are going to go really quickly through medical indications for supplementation because we already led into that. And really it's just kind of encouraging you all to review what's out there in terms of the evidence and the research around supplementation. So World Health Organization and UNICEF, as well as Academy of Breastfeeding Medicine, all have recommendations, protocols, and guidelines for supplementation and what it looks like. I did include the ABM protocols in the chat, so hopefully you all were able to look at that. Again, the amount of supplementation really is just dependent on what the baby is doing. So if we are not able to see what baby is doing, there are some guesstimates that we can kind of determine based on the baby's age. The important thing with supplementation is not overfeeding, and then protecting mom's milk supply is also equally important. So if we do have to use human donor milk or formula, we still need mom to express or pump her breast so that we are able to increase her volume. As we're waiting for that volume to increase, we're not, starving babies. So babies are allowed to be able to eat, and that's where formula comes in really nicely. The other piece about formula that's really important, especially, given the recent events, is education on proper formula preparation. So all families should know that if they're using powdered formula is not sterile. So I always get the question, should I use bottled water or the special baby water with the, cute picture of the baby at Target or whatever? And I don't actually care what water that the parents choose. I just care that they've boiled it. So again, proper formula preparation education is really, really important whenever moms are using or families are using powdered formula. If families have access to the ready to feed and can afford the ready to feed, that's actually the recommendation that we give in lactation, just based on the fact that it is easier for the baby to digest for the first few months. If parents don't have access to that, it's not available, they can't afford that, and they are going to use the powdered formula, we want to teach them about proper hand washing before they're handling any of the parts. We want to teach them that they have to boil the water, whether it's distilled, bottled, or the special baby water. It needs to be boiled and then cooled for about 5 minutes and then mixed with the powdered formula in order to kill whatever is in that formula can. And the CDC also has some recent guidance that they have released because of the whole formula shortage. They recommend all babies under the age of 2 months and immunocompromised babies get the formula mixed with boiled water. I recommend all babies do, because no matter the age of the baby, if we're using powdered formula, there are things in it that need to be killed in order for it to be safe for a baby. So I do recommend looking up some of that information just for your own knowledge so that we can educate parents appropriately. So we're going to do 2 more cases. This is baby D, 24 hours old, C-section delivery of mom with another child. Mom is combo feeding because she had difficulty with latch. First child was initially combo fed, but then mom switched to formula because she felt like it was easier. This particular baby is giving about 1.5 ounces of formula per feeding, and mom states she's trying to latch the baby, but he's too sleepy. Mom does want to breastfeed and try a little bit more with this particular baby. So what are some feeding plan recommendations that we would give for this dyad? Nobody? Come on, y'all. You've been doing so good this far.
I think this baby might be a little bit milk drunk. 1.5 ounces of formula sounds like a lot for 24 hours. So that's probably why he's.
You are so right. So right. I love that you recognize that. I was trying to sneak it in there to see if folks recognize it. So I'm glad you caught that.
Yeah, Carolyn was also commenting that that's a lot of formula.
It is.
And Janet was saying breastfeed baby first, and then if needed, supplement. And Lilia also has her hand raised. So I'm going to unmute you, Lilia.
Yes, feel free.
Hi, the only thing I wanted to add, yes, the mom is definitely overfeeding with formula, but I do see C-section moms just have delay sometimes in the onset of lactation, and they try to hand express and they don't see anything coming out. So they give validation to their thought that I have no milk, and they don't have a good concept of, okay, so patience is a virtue. I really have to work at it and breastfeed the baby first before I offer any supplementation, and then just offer enough, like half an ounce, 15 to 20 mL of formula after breastfeeding. The other thing that I usually tell moms to is not wait until the baby is really crying vigorously and looking like they're really hungry, because they tend to be very frazzled and they don't focus on latching. So staying on top of the breastfeeding and offering the breast before the baby is really frantic helps a lot with the baby kind of giving a good breastfeeding session.
Yeah,
Absolutely,
so
I love
good.
that.
That's great. So you guys all got it. This baby's being overfed. This baby is milk drunk. This baby does not want to wake up to feed, right? So what would we do for this particular baby? We would do skin to skin as often as possible. We would educate on appropriate latch and positioning. We might even offer a different position. Side lying, FYI, is a great position for my C-section mamas because it doesn't put any pressure on that incision, and they're able to actually relax, and that lets that oxytocin flow. So you might practice your experience in supporting side lying as a position for C-section mamas. Obviously offering breast before any supplements that we're doing, reminding them about tummy size, hand expressing when possible, and spoon or cup feeding any expressed breast milk. Providing a pump is also important, encouraging pumping if mom is giving those bottles. And then if mom chooses to continue formula, we're going to educate on newborn tummy size and reduce the amount of formula given, right? As always, we want to follow up with lactation, both inpatient and post-discharge, but it might be just a reminder. And as Lilia mentioned, reducing that amount for that 24-hour-old baby to half an ounce will help the baby to have more opportunity to learn how to latch, to be awake to latch, and to be more effective in terms of latching. So you guys hit that one on the head. All right, we're going to do another quick case. This baby presents for newborn exam on day of life 4. Primary C-section delivery to a mom with gestational diabetes, diet control during pregnancy, and this kind of speaks to Lilia's point before, which we're going to talk about. Birth weight was 4,200 grams, and baby's at 11% loss from birth weight. Mom is currently exclusively breastfeeding. What would be the feeding plan recommendations for this baby? I guess maybe in the interest of time, I can also just go through them really quick. Candace, what do you think?
Sure. Why don't you go through this one, and then Jocelyn had 2 questions that are a little bit interrelated in terms of whether you recommend teaching pace bottle feeding with formula administration, or you could even consider that for pumped milk that you're using supplement in a bottle. And then how do you correct for if a mom has been overfeeding the baby? How do you advise her to kind of correct for that or go about changing that strategy?
Great question. So let's do this case first, and then I'll answer those really quick. So this particular baby, we want to have mom breastfeed both breasts every 2 hours. Remember, this is an outpatient baby, but it was a C-section delivery. So we're on day of life 4. We would want mom to pump after breastfeeding if she has access to a pump, and offer between 1 to 1.5 ounces of expressed breast milk, human donor milk, or formula after every feeding because of that 11% weight loss. We are also assuming that we haven't done a full feeding assessment, so we don't know how much baby is shrinking, okay? If mom does not have a pump, we want to think about ordering a DME pump for her. There is coverage for breast pumps as well under the Affordable Care Act. So you'd want to familiarize yourself on that being an option in terms of resources, because it should be covered and mom shouldn't have to pay for it if she can't. Educating and providing resources for human donor milk. If mom wants to exclusively breastfeed That means she might be open to providing human donor milk for her baby as a supplementation option. So here we just listed the Mother's Milk Bank, which is the San Jose Milk Bank, as an option, and then the University of California Health Milk Bank in San Diego. And then I would want this baby to follow up for a weight check the next day to make sure that this plan is working. And to Jocelyn's question, so the first one about when a newborn has been overfed formula, it's a hard thing, right? Because I think we can all take a look at our fists, which they tell us is like, this is how much our tummy size is, right? But we can all eat a whole lot more than this. So we can all overeat, and we all know how we feel after we overeat too. It's not always the greatest feeling. Babies are just little humans, so they feel those same things. So I would just be talking to mom about what it does to the baby. I would be educating her on trying to do skin to skin more. And then from that point, once you recognize that baby is being overfed, you want to kind of reduce those amounts incrementally. The hard part is if it's been a couple of days, baby's tummy has already been stretched more than we would like it to have been stretched. So in order to satiate baby, we might have to do a little bit more, but we would want to ideally titrate or wean down a little bit from that supplement amount. And you don't do it immediately, right? So it's not, we go from 1.5 ounces to now we're giving a 1/2 ounce, right? You might need to do it in 10 mLs less, 15 mLs less for each feeding until baby gets used to that. And then pace bottle feeding is also a way to do that. So yes, highly encourage that. If you're not familiar with it, we do want to encourage pace bottle feeding regardless of what's in the bottle. So that can be for express breast milk or formula. It allows baby to control the feeding versus mom or dad or provider controlling the feeding. So baby will mimic more of what they would do at the breast if they are being pace bottle fed. So that's also something that would be important to educate yourself on, so you can better educate your patients and better support them. And I see Hope has her hand up. And again, we can finish through this really quick, but for those who have to hop off, we definitely would encourage you all to fill out the evaluation if possible. And I know Candace just put it in the link. And Hope, go ahead with your question. Candace, I don't know if you can unmute her.
Yep, she's unmuted. Go ahead, Hope.
Well, it's more of a commentary than a question, which is that for most hospital or even outpatient settings, the smaller Nursette bottles are at 60 mLs, right? And so we give parents 60 mLs and we say, feed the baby. And so they think that those 60 mLs are supposed to fit. Sorry, the plane's going overhead. That those 60 mLs are supposed to go inside the baby, you know, and I think that's an industry standard that needs to be addressed, where we ask the people making the Nursettes to make them in smaller sizes so that there isn't this impetus and desire to make the baby finish the bottle because you don't want to waste it.
Yep. Because that milk is not cheap, right? Whether it is human milk or formula, it is not cheap. And highly recommend that. You know, that is that's a societal problem that we have here. When the smallest bottle that you can find is 2 ounces, right? And it looks like this, but we're trying to educate on tummy size that looks like this. And then we're handing them, this is 1.5 ounces, right? It's kind of hard to see in the sun, I apologize. But how are we going to educate on tummy size like this for a newborn, but then give them a full bottle? So, you know, I had nurses at the hospital I was at that would literally pour out half of the bottle into the sink, right? Because this isn't money that's going down the drain from the parent. This is from the hospital. So they can actually show them, and it has the mLs on the side. So that's another way, you know, as we wait for society to catch up in terms of those things, that's another way that we can actively, you know, address some of these challenges so that the mom does not overfeed the baby, and we can encourage breastfeeding and things like that. So that's a great point. So as we kind of wrap up here, I just want to remind everybody about, you know, providing the appropriate guidance and counseling based on the patient that's in front of you, and really receiving that feedback on their individual experience and taking into account what their individual feeding plans are and their feeding goals are. Again, I want all babies to have access to their mama's milk, but that's not always the plan for everybody. And so it's really important that I am supportive of this particular family's goals while assessing the clinical needs, while assessing levels of support. We also want to remind families about normal newborn behavior. Yes, babies have gas. They're little humans. All humans have gas. we, I think, all probably know humans that are more gassy than others, right? And so some babies are more gassy than others. It's not that something you're eating is causing this baby to be gassy and we should all of a sudden stop, breastfeeding or providing breast milk. So doing some of that really, the anticipatory guidance around those things can really just help quell some of the parents' concerns and their anxieties around their feeding their baby. In terms of expectations for feeding, again, talking about feeding frequency for the first 2 weeks and beyond. We want to talk about that first growth spurt that happens at 2 weeks, because we often, sometimes in pediatrics and outpatient, they're seen for the newborn exam and then not seen until 2 months. But we're getting messages that they're concerned that their baby at 2 weeks old is all of a sudden so hungry and wanting to eat every hour. And what happened to every 3 hours, right? And so we need to talk to patients and parents about growth spurts and what to expect, and really just encouraging them that this is part of the normal growth period. And then there are different factors that impact infant feeding. So we talked a little bit about them: folks' access and availability for pumping, availability for this idea that everyone has the ultimate, situation that is conducive to breastfeeding support. And we know, unfortunately, in this country, we actually don't have that. And that's why we are the worst in terms of the developed world as far as our breastfeeding rates. We're also in a future session going to be talking more about those cultural impacts as well. So not just the social determinants, things like having to go back to work and not having paid leave, but also how culture influences, feeding decisions for families. So those are just, this is just the starting point for this session, and we hope that it was informative. And I'm going to pass it off to Candace for a few of our upcoming opportunities.
Asaiah, I just wanted to thank you again today, and everyone, for all of your active participation. I have been really floored, and I'm just so grateful for today's dialogue and conversation. This has been a long time in terms of planning, and it so far exceeded my expectations, having you all with us today and sharing all of your different perspectives and experience, and being open in your dialogue. So thanks for sharing this space with us and being willing to open up this conversation and start to Asaiah's point, build some of these bridges between lactation and pediatricians, because as Hope mentioned too, right, we're all really on the same team. And so in terms of upcoming opportunities for more learning together, I put a couple of our flyers in the box as well, the chat box. So our second session in this series will be coming up on August 4th. It's another, I believe that's actually a Thursday, again from 6 to 7:30 p.m. So thanks for joining us late in the day. And if you can't, you can watch the recording as well afterwards. There's a registration link on that flyer. Asaiah will also be having some amazing clinician / healthcare provider focused office hours this summer as the inaugural Biddy Mason Lactation Fellow for the Charles R. Drew University Black Maternal Health Center of Excellence. And really, it's a space for you to drop in, just like you did in college during your training, to have a question answered. If you've got a burning question or a kind of an interesting situation, or you have this patient, you're not quite sure what to do, and you're looking maybe for some more guidance or resources, stop in and chat with Asaiah. She'll be on her Zoom link from 12 to 1 p.m. on Tuesday afternoons. So over your lunch hour, you can pop in. The flyer is in the chat box, and I will go ahead and also email it out to everyone who registered, and feel free to spread the word. And lastly, World Breastfeeding Week and month is coming up in August. And in celebration of Black Breastfeeding Week from August 25th to 31st, we're also going to be planning a third session with a very specific focus on breastfeeding equity, and supporting Black mothers, infants, and families on their lactation journeys. And so we're tentatively planning it for August 25th at 6, so save the date. More information to come. We're working on that. So just thank you guys. Again, feel free to share the information on the session with all of your colleagues too. This has enduring CME, so it's free to any providers who want to watch the recording for quite some time after today, actually. And you just have to fill out the form to get the credit. And I'll pass it off to Asaiah for her final thoughts and words.
No final thoughts, just thank y'all. I'm so glad to have been able to share the space with everyone. I didn't get to see faces because I was too busy sharing my screen, but I really hope that this is just the starting point for how we can really think about incorporating lactation into practice to better support families, right? Because again, this is not, it really does take a village, and we are part of the village for these families and for these babies to grow up nice and healthy and strong and amazing. And that's regardless of the way that they choose to feed their babies, right? We just want to support families to be able to do the best that they can with the best support and information that's available. And so I'm just really grateful that you all were here. And so feel free to hop off, but I'm able to stay for a few minutes if anybody has like lingering questions that they didn't get answered. I'm happy to chat for a few minutes too, but thank you so much, everybody.